of the Oregon Health Policy to day one of the Oregon Health Policies Retreat. Go ahead and get settled in, everyone, and we'll just ask that that everyone can place themselves on mute unless you're the presenter at the time, and we will go ahead and get started in just a moment. Okay, I think it looks like we have significant representation from the board. Welcome everyone to day one of the Oregon Health Policy Board's retreat. I'm Tara Chetok, the project manager for the board, and I'm going to turn things over to our chair, David Bingsberg, for a quick welcome.
Thank you, Tara. Welcome everybody. Great to see you. Really appreciate the discussion we just left from. Thank you, Clarice and Diana, for organizing that. I think many of you know that this is my last meeting as chair of the Oregon Health Policy Board, and I wanted to I started signing up for California health insurance, and California is just driving me crazy with spam calls. California has a few things to learn from OHA, I'm sure. Anyway, this is my last meeting as chair. I just would like to take a chair's prerogative just to share a few notes of appreciation before we get started. I returned to Portland 6 years ago to come back to my hometown, and there are two opportunities I'm really, really grateful for. The first is start a new school of public health, the OHSU PSU School of Public Health. Last week, we were ranked on the top 20 and top 25% of all national schools of public health, which is something after 6 years. I think we did this because we grew our enrollment, we doubled our research funding, we recruited national leaders like Dr. Margarita Lightfoot, who I hope you'll consider when my spot is open in a couple months. And also we developed, I think, a leading program on the West Coast regarding anti-racism social justice. I'll always be grateful for that opportunity to start this new school. The other opportunity I'm always be grateful for is being on the Oregon Health Policy Board, and not only the Oregon Health Policy Board, but the Health Equity Committee and the Public Health Advisory Board. I am grateful because of all of your good work and the learnings I've realized from our discussions. In the last 6 years, we've launched the Cost Growth Target Program. We've supported 1115 Medicaid waiver renewal application. We had serious discussions about Medicaid redetermination, made significant progress for diversifying the healthcare workforce in Oregon. We really elevated the committee's work that collaborate with the Oregon Health Policy Board, and just finished a great discussion with the committee chairs and vice chairs. And we onboarded new committees, the Behavioral Health Committee, as well as the Marketplace Advisory Committee. We are really pleased that we welcomed, we have a full slate of board members. We welcomed 3 new policy board members, Bill, Jessica, and Sandy. Great to have you on the team. And we did all these while managing a COVID pandemic and supporting OHA to achieve one of the lowest per capita mortality rates of any state in the nation. Really quite a success. And all this work, all the above work, was really centered on health equity with the goal of ending health inequities by 2030. We've come a long way since the first discussions I participated in, which was all around CCO 2.0. CCO 2.0 was a great effort, a great accomplishment, but there's so much more that you have all accomplished since then. And I have learned a lot in this process. I do my best learning when I'm surrounded by great people doing important work, as all of you have done. I've learned so much from you, I want to thank you for having the opportunity to learn and engage in challenging and important discussions, to question assumptions, and to move the change forward that is so desperately needed. I've learned from you through these public deliberations about Oregon Health Policy Board meetings. I've also learned from public comment. We want to thank the public for showing up and providing comment during their meetings. I also have learned enormous amount from many of you through one-on-one chats, through field trips pre-COVID. God, I miss those field trips. And I've learned from each of the OHA staff. I really want to thank Pat Allen, Jeremy Vandehey, Trilby DeYoung, Seth Jerem, Jeff Scrogan, and Tara Cheacock to you for your learnings and support along the way. Also want to thank previous chairs Zeke Smith and Kara McElvery, who did a great job. And I also want to call out a special board member, Felicia Hagans, for holding us accountable, and which I think many of us remember. But I also want to recognize that many of you missed the best part of the Oregon Health Policy Board, and that was our 8 a.m. discussions every Tuesday, where we would discuss the board's work and plan for these meetings. These were discussions with Tara, Steph, Trilby, Jeremy, Oscar. Oscar and I would often chat after the meetings or call each other, talk about the transition of the chair role and other board business. Really thank Oscar for developing a really trusting, highly effective relationship and fully leading into this work. I know that Oscar is going to do a great job leading this board with calm, effective leadership, a deep commitment to continuing to work on health equity. And we couldn't hand over the baton to anyone better and anyone more dedicated to help support this group. And Kirsten will be similarly do a great job as vice chair. And I look forward to following your good work as a member of the public in 2 months. But let me just leave with one last message, and I hope this comes up. I'm sure it will come up during our retreat today. And one last message is a word of encouragement that I hope that during our discussions today, and after discussions that follow after I step off the board in May, that we take the governor's priority to end health disparities by 2030 as our top goal. And we move forward not only as a goal, but developing an action plan towards that goal. And I know the 2 committees that I have served on, HEC and FAB, are very, very committed to that goal. I think they would have enormous contributions to make from transforming how we understand public health, from doing the greatest good for the most amount of people to a new concept, and that's the greatest reduction of health disparities. 2030 is only 7.5 years away. That is roughly 3 2-year terms on the board. So there's a lot of work to do, and I look forward to following all your great work. Thank you.
David, thank you so much. This is Diana Bianco with Artemis Consulting, and we're going to do introductions, but really want to honor your service, David. Thank you so much, and we do have time at the end of our retreat as well to share a little bit more about that transition. But thank you so much for your words as we get started on the next 2 days. Want to just, because we're in, just kicking off the public meeting, I want to, we're going to do member introductions, and we'll just get started. I'll go down the list of members, and then Clarice and I'll introduce ourselves, and we'll talk a little bit about the agenda and moving forward. So David, I know you've just introduced yourself, but let's start again so we can have name, pronoun, race, ethnicity, and then we'll move through the list of board members. Thank you.
David Banksburg, use he, him pronouns, chair of the board and dean of the OHSU PSU School of Public Health.
Thank you. Brenda.
Hi, Brenda Johnson. I use she, her, AF pronouns, and a member of the board. Pleased to be here today. Thank you.
Oscar.
Good morning, everyone. My name is Oscar Arana. I use he, him pronouns. I'm the vice chair of the Oregon Health Policy Board, and I identify as Mexican and Indigenous.
Thank you. Kirsten.
Hi, my name is Kirsten Isaacson. I use she, her pronouns and member of the Health Policy Board.
Ebony.
Good morning, Ebony Clark, she, her pronouns, and member of the Health Policy Board.
John.
John Santa, he, him, OHPB member. And I think under the circumstances, I need to make sure I declare myself, I'm a senior. I'm 71. So it's folks my age who are dying 70% of the time with COVID.
Thanks, John. Sandy.
Good morning, Sandy Sampson. She, her, Native American, member of the Confederated Tribes of the Umatilla Indian Reservation, and I am very excited to work with this group. Thank you.
Thank you, Sandy. Jessica.
Jessica Gomez, member of the policy board, also in Southern Oregon and CEO of Rogue Valley Micro Devices. Thank you.
Thank you. Bill.
Hi, good morning. Bill Kramer. I use he, him pronouns. For those who weren't on the earlier call, just to not alarm folks, I just had a minor medical procedure, nothing life-threatening. And I got my second vaccine booster yesterday, so I'm feeling well protected, but sore-armed.
Thanks, Bill. Did I get all the Health Policy Board members? Okay, and I know we also have OHA staff and leadership here as well, and they'll be doing some presentations throughout the morning. I'm Diana Bianco. I use she, her pronouns, Artemis Consulting. Clarice.
Hi, good morning and welcome. And hello back again, folks. My name is Clarice Bailey. I identify with they, them gender pronouns. I'm from C. Bailey Associates, which is my little consulting gig. I'm Black American.
Thank you. I'm going to do a brief agenda overview. We're really excited to be with you. Lots of discussion and planning has gone into the next 2 days. And just to sort of the goals are really to look again at your 2021-2023 priorities, make sure those are still the right ones, you're committed to them, to look at the your work over the last year and the committee's work, sort of looking at those accomplishments and also be thinking about the 2022 work plan and really focusing on the Health Policy Board's opportunities for systems change to eliminate health inequities, to focus on the anti-racism work that you all have been doing, really important stuff that we started some of that conversation this morning with committees. And so we'll be sort of pulling through a lot of these themes as we have the conversation. This morning, we'll be doing some context setting. Clarice is going to walk us through sort of a refresher on systems change that we had sent out in advance. We'll be talking about that. And then we'll be doing some look back on 2021, as I mentioned. And then hearing from Leanne Johnson, Ignatius Bell, Susan Otter on the board committee membership work group. And this has been an ongoing conversation for all of you. And we'll be having some focused discussion there as well. And then tomorrow we'll really be focusing on sort of where OHA is at and sort of how you all work together and thinking about updating those 2021-2023 priorities. So that's a real broad overview. And this is your retreat. This is not our retreat. And so you all should be pushing back on Clarice and me if we're going too fast, if we're going too slow, if you want to stay focused on a particular agenda item. But really, we want you to come out of this having some good and deep discussions to sort of be able to step back and then also be looking forward. How do you do the work that you all want to do to get to that 2030 goal? We're both honored to be with you and to work with you over the next couple of days. With that, I'm going to turn it over to Clarice, who's going to just sort of walk through again this idea of systems change as we think about addressing racial disparities and health inequities. Clarice, please.
Thanks, Diana. And of course, I put a throat lozenge in my mouth, so now I'm, like that. Chloe, thanks for bringing up the slides. We sent you an article for your consideration. It's an article, it's a chapter out of a very recent book. The article was entitled Racial Justice and Power Sharing, the Heart of Leading System Change. And the book is actually a collection from Public Health, which is where we are, right? We are absolutely at the place, if we are serious about doing this work around equity, inequity, using this health disparities as our metrics, talking about anti-racism and all that lives with that, then we're really talking about significantly changing the systems, the human service systems in which we operate. So that commitment is really about, see, I'm going to steal it already, John, not just driving the 2001 car, but buying a new car and keeping, getting on the road in a way that we can. And so we offer this notion of systems change, systems look at as kind of the North Star for that, as kind of the thing that we can keep our eye focused on. We sent you also, and Chloe, you can move ahead. We sent you this iceberg notion, right? Icebergs are 10% you can see, the rest lives under the water. Titanic didn't have technology, ran into all the stuff that was under the water. The DiCaprio, the whole bit, right? Iceberg is how we get to think about systems, because so much of what's going on around equity, inequity, racism, genderism, classism happens way below the surface. So at any point, if you need to stop me, feel free. You'll probably have to yell to make me, to get my attention, but I encourage you, don't hesitate. So system transformation requires that if we're serious about doing this anti-racism work and this equity work, that we rethink how we think, how we approach the work, who we approach the work with, how we invite people, all of that. And requires us to take a structural, a systemic, so across the board structural approach. I'm not coming to this conversation with the assumption that this is brand new, oh my God, news. I'm coming to this conversation with the assumption that every time I think about systems change, every time I read about structural change, trying to get to a better place around moving us away from the inequities, I learned something. So on the one hand, this is my, selfishly a continuation of my learning and an offering. So when we talk about systems change, we're not talking about taking off the table the conversations around hearts and minds, right? Those conversations, changing people, changing the way that people come to the world, operate in the world, their experiences, has to stay in the conversation. What we are saying, though, is that systems are created by us. And so systems get changed by us, and systems have to be accountable to us. The work that we do individually has to bubble through all of the pieces of our iceberg, of our system, out of our commitment to see inequity stop. So we have our individual actions, and our individual actions then inform collective behavior and collective practices. So being curious, thinking about, listening to all of the pieces that came from this morning's conversation, right? From the conversation with the committee members, all of that helps us construct, deconstruct, reconstruct this system. So Chloe, if you give us one click. The very top of a systems iceberg, right? If I had more artistic ability, this would look like an iceberg, but what you get is a triangle. The very top are the things that we can see, right? The visible, maybe written down, my experience, events. This is only 10% of an iceberg, right? Iceberg, 10%, you see the 90% Titanic didn't have the tech. Chloe, if you click, we'll get some examples. So when we think about the historical and contemporary things that are in our face, that we see, that we could talk about, that we let roll out of our mouths, we talk about not having representation, whether that's language representation or it's, physical representation, people that look like me giving me services. We see the impact of maintaining that lack of overtime. We see it in the word disparities. Disparities is that metric that measures that impact. We see it in continued over decades disproportionate confinement of folks, people of color, indigenous tribal folks, folks from sovereign nations, poor people in the criminal justice system. So none of these examples are meant to be exhaustive, right? These are just some of the things that we see. If we had the camera and we took the snapshot, that's what we would say. Oh yeah, we've got too many people of color in the criminal justice system. And that's been over time. Chloe? And so over time, these things become habits. They become our practices. They become things we don't even really think about too much, right? Because they are just, as my mom would say, they're just in the water. They're just in the water. But these patterns and trends aren't in that 10%. So we don't readily bring them to mind. We're not quick to talk about them. They're not in our little camera lens. But they do serve to reinforce and hook together inequities that happen in education, that happen in public health, that happen in criminal justice, that happen in trying to figure out how to deal with people being unhoused, that happen in wages inequities, that happen, right? They hook all together. The patterns hook them. They're the connectors. So some of the examples of that is Oregon has a huge history, a huge practice of being exclusionary, right? We know the history of Oregon was not created with Black folks or sovereign nations or folks from China in mind, right? And those patterns reinforce things like disproportionate criminalization of folks with behavioral health concerns. these patterns become methods of social control. Chloe? And over time, we mold and mesh our patterns into our policies and our laws. So we have ways that we use the legislature, the Constitution, to create who gets what, who is removed, who is invited, who is not, what they're supposed to do if they're invited. And it really is about the distribution of power and resources. Chloe, we'll get examples. So Sundown Laws. I am recently back to Portland myself. And so imagine the stun on my face when I'm on the East Coast listening to, oh yes, another Sundown Law was taken off the books not that very long ago. A couple, 3, 4, maybe years ago. Broken treaties with sovereign nations, genocide. All of this gets baked into the way that we legislate and say that you're not in compliance. The requirement to have dominant culture credentials in order to heal, even though we know that people of color and indigenous folks have been healing populations over multi-generations, multi-centuries, but that not being good enough. And finally, the big chunk, Chloe, yep, the big chunk at the bottom is where our values, our beliefs, the stories that we tell get further baked into organizational culture. So some of the language that we use to talk about how we bring voices to the table. We invite people to come and tell their stories. Then the stories have been told over and over and over again. The stories are not different stories than they were in 1997. They may have new tenets, but they're still the same old stories. So how many times does a system, do we need to hear somebody's story of not getting the services that they need before we get it, that we need to change something? The relationships that get established, right? Not being able to understand why there's no trust of a system that hasn't provided the services that people need. Chloe, you can hit the last one. We have implicit bias that lives in us, which keeps us safe. We have implicit bias that lives in our organizations because we bring that, because systems exist because we built them. And so we get to change them. Stigma happens because of our attitudes about the person that lives in the tent outside of my apartment building. And that gets woven into how then I decide what the next policy is going to be. And that gets woven into then the practices that make those links to inequities. And all some people can see is that that guy is really nasty and he yells at 12 o'clock at night. So we're inviting you to take a systems look, a systems approach, a systems walk towards this thing about equity. Like, equity is not a new conversation. We had cultural competence, we had diversity, now we've got equity. We're really talking about, fundamentally, we're talking about anti-racism and all of the pieces that live underneath the water that happen as a result of a lack of examination of how racism has shaped our systems, the systems of human services, right? So we're nudging you to develop a shared analysis of the Oregon Health Authority and everything that come, right? So that would be our 10%. Everything that happens underneath that iceberg, whether it's the OHPB or the committees that somehow magically got created between OHA, the legislature, all y'all. We're asking you to build a shared analysis around this, recognizing that in a state like Oregon, where it has a 70-some% white population, the people that hold the power are white people. And so white people have to do the work to begin to figure out this analysis, right? It's great to have all of us in this together, and the people who hold the power are the people who get to make the structural changes. So the folks who wrote that article, Gould and Farhan, say that really the shared analysis, I'm going to read it, developing a shared analysis of a system is a crucial first step of leading systems change and a prerequisite to developing solutions that actually solve systemic problems. We've been in this conversation so long that now is your time, right? Now is your time to do this differently, to actually make a difference, to actually change the way that Oregon does health. Last slide, Chloe. So we're asking you to keep these things in mind. One, Chloe. As you go across these next 2 days, hopefully something will stick and you'll carry it beyond the 2 days, but particularly for the next 2 days. Any of the things that you're talking about, past, present, future, representation, makeup, anything that you're talking about, we ask you to put it up against these questions. How might the outcome of what you're doing lead to racially disparate outcomes? How might any piece of what you're doing end up being, and you heard some of that in the conversation this morning, that maybe we're creating new injustices, right? We have to be vigilant in order to not do that. And one of the ways that I find is helpful, this comes out of Foundation World actually, that's helpful to keep that in my mind, is to always ask myself, who benefits from this decision? Who benefits from this policy? Who actually is going to do better because of this? And who bears the burden? And the last one, how will you know? What are you looking for to let you know that the efforts that the Oregon Health Policy Board, its committees, Oregon Health Authority is making? How will you know that it's making any difference in the lives of folks? And so this is what we're asking you to do, right? This is what we're asking you to put in your brain, to let your mind form how you go through the next 2 days. Black feminists, right? Black women feminists remind us that if we address, we, big we, country we, state we address racism, everybody gets better. If we don't remember that white folks bear a burden by not changing our systems, then if we forget that, then nobody gets better. If we don't address racism, nobody gets better. And so our beg of you is to keep these things in mind and to lift all of us by paying attention to those who we've made choices, developed patterns, created laws, and had implicit bias against. So that's the context of your work for for the next little shindig of 2 half days that we want you grounded in and that we invite you to think through. We have a little teeny bit of time, and so, or we don't, Diana, do we? We don't have no time, do we?
I think that I would pose the question, Clarice, I think you would probably pose whatever question you were going to pose, please.
If there's anything anybody wanted to say.
That's what I figured.
Yeah, if there's any input that you want to lay on the table for each other, or thoughts, or slowing down is one of the things that is anti white supremacy. So I'm good with slowing down. Any thoughts, comments? Chloe, thank you so much. I'm so glad I gave up the control. Feel free to just let it sit too. Sandy, I see you came off mute.
Thanks. So I guess another question to drive some of the, whether it's inequities or inequality, is in regards to, health population, the greater the level of stress in deeply unequal societies, the stress wears you down. And those lead to, health disparities. So how do we address that within this confines of what we're doing during this next 2 days? I mean, for a person of color, it is what it is. You don't let it define you. I mean, that's what I believe. So I guess I'm just curious on where do we take that as far, I mean, is it proven? Is there data? What kind of data actually relates to that and so forth? So.
Are you asking me, Sandy?
I'm just posing the question to the board. I'm new. I've worked with numerous individuals on this board and the Oregon Health Authority. So I guess I'm just posing that question.
Great. Thank you.
Any takers?
Yeah, this is John Santa. I just might share, I've been fortunate to be part of this task force on universal health care, which is focused on designing a universal health process. We could talk about that more later, but we got our first draft of the actuarial report. And within it was an analysis of how are the streams of revenue paid. And basically, if you look at Medicare and consider it to be at 100, Medicaid pays 85. But the real attention getter is commercial pays 170. Do you think that there's obstacles for Medicaid patients? Do you think? Do you think there's obstacles for Medicare patients? I mean, where are the most vulnerable patients that are in Medicare and Medicaid? And imagine if that all went away and every patient was funded at the same amount. So in the delivery system, there would be equity in terms of payment. I mean, it's just such a gripping example of where we're at because of the system we've chosen to pursue. We just have huge inequities driven by money. In the 2001 car, we're trying to drive.
Which lands directly in policies and laws, right? That then promotes the habits that we make. Can you think about redistribution of wealth, of money, of power? Or do only certain folks deserve to have any of that? And so hopefully this feels a bit heavy. Hopefully this hangs a bit heavy on you as we go into the rest of the conversations, because this is hard work. If it was easy, I suppose we wouldn't be having conversations about racism, but we are, because we have to. And so here we are. So welcome to the 2022 retreat.
Clarice, thank you so much for that. And this is the beginning, the continuation of a conversation. We're going to be, as Clarice mentioned, we're asking you to hold it. And it's hard, and we'll do our best. We'll all do our best together. But we'll come back with some questions. And as we sort of shift into the next piece, right, we have this framework, and shifting into the next piece about thinking back on your work in 2021. And again, this should be informing how you think about your work for 2022. And so Tara's going to sort of walk us through some of the 2021 work, sort of reviewing and reflecting. And then we have some questions for you, and just want to hear some of your reflections so that it informs some of what you want to do in the coming year, and so that you actually take the time to recognize and sort of acknowledge, celebrate the accomplishments of the work, not only of your work, but of also some of the committee work. So I'm going to turn it over to Tara.
Great, thank you, Diana, and good morning, members and everyone participating today. I'm Tara Chitak. I'm the project manager for the Oregon Health Policy Board, and I'm going to walk through, maybe I'm going to sprint through the highlights from last year to try to make up some time here. So Chloe, if you can go ahead and go to the next slide, please. I also want to direct your attention to a handout in today's retreat materials. That includes a lot of summary information that will support these slides. So since we'll be moving quickly, go ahead and look at that for additional details. For today, we are going to do some context setting and then go through the highlights. And like Diana said, some discussions. So Chloe, go ahead and if you want to move up a couple slides to 4. Perfect. So last January, to start off the year, we heard from the governor's office, and Kate Brown wrote the board a letter asking the board to focus on centering its work on health equity, implementing the cost growth target program, and supporting OHA's 1115 waiver renewal. And at the following month's retreat, you all agreed to focus on those 3 areas. And then the board had also added a 4th priority of focusing on its committees. And you'll notice there's some color coding here on the screen, and that will be reflected throughout the presentation in terms of where items are related to these priority areas. Next slide. And when we talk about health equity, we are talking about the definition you see here on the screen. This definition was developed by the board's Health Equity Committee and voted to be approved in 2020. And then this last year, we added, you all approved to add the addition of age. So when we're talking about health equity today and always, this is the definition that we're all universally working from. Next slide, Chloe. And then last year at the board's retreat, we also adopted this framework of roles. And this helps us to understand within different bodies of work, when they come to the board or from our committees, we're understanding how the board is helping in that body of work, whether the board's going to be a leader, like with the cost growth target program, more of a collaborator, like when we're talking about board members who are committee liaisons, or when the board is supporting. And a lot of that we saw with the 1115 waiver last year. And then also there's many opportunities for the board to be a communicator. And we've all seen that, and you've experienced that through the legislative updates and COVID updates. So those is just to give you some context there of how we will move through the remaining of the presentation. So Chloe, next slide, please. Okay, we're going to go into some details of meetings, and I think we can skip most of these. Just kind of wanted to highlight that the board did have several votes over its meetings last year, 13 total, and these are categorized by your priority areas. We heard over 46 updates last year, and you had oral and written public comment. There were 79 of those that came before the board. Yeah, you can go ahead and go back to the webinar slide. And then looking beyond the board's monthly meetings, you guys also had 8 webinars with 350 attendees, and the topics are listed here on the page, and more coming this year. So quite a bit of work and time from the members focused on its priority areas and supporting topics. Next slide, please. We're going to focus right here on the waiver. So at the 2021 retreat, the waiver team presented this slide, and these were the opportunities for work for the board and the timing for when they would be completed, as well as the board's role. And you'll see here and in the supporting meeting attachment that I referenced, you guys completed all of the requests of the waiver. You reviewed the policy concept papers, you approved the draft application, you even had public forums for public comment at your December meeting, as well as the January meeting of this year. The next slide, please. And then at last year's retreat, we also heard from the cost growth target program, and they outlined these bodies of work that the board could help support. And most of those were successfully completed by the board. You'll see a couple items, the plan for monitoring for negative outcomes and the plan for quality measurement. Those have been started, they are not completed. And then the performance improvement plan template processes, that's going to happen this year. So those are happening now, not completed yet. And again, we're moving through this quickly, so we can take some comments at the end, but again, you can see the accompanying summary attachment. Okay, Chloe, next slide, please. All right, so when we're looking quarter by quarter of last year, here are some highlights that I pulled out from accomplishments within our meetings. And so wanted just to note that early in the year, we approved the Healthcare Workforces Fund for Scholars request. We also approved the recommendations report from the Cost Growth Target Program, and you adopted your priorities and updated our guiding principles for decision-making document. In quarter 2, a notable item again was adding age to the health equity definition, supporting the kindergarten readiness measure. That's when we spent a lot of time too in quarter 2 is on the draft waiver concept papers. And then also quarter 2 was when we had some legislation passed, which approved accountability for the cost growth target program, and also separate legislation resulted in new committees for the board, which is the Behavioral Health Committee and moving the Health Insurance Marketplace Advisory Committee over to the board. Next slide. Quarter 3 and 4, we have additional highlights here. One of the big bodies of work that we've been focusing on throughout 2021 was the committee membership work group, which we'll hear an update from them in just a moment. And also wanted to call out that the Healthcare Workforce Committee, you approved and supported their health equity framework. We welcomed both the High MAC and Behavioral Health Committees to the board. So lots of bodies of work here. And again, I'm trying to make up time so we can't go into all of the details, but here they are. And then Chloe, let's go ahead and go on to the next slide too. And here, and you'll see also in the newest committee digest that is linked to on the agenda and will be presented with retreat day 2 materials, is a lot of our committees have been working hard and they had many accomplishments last year. And so here I've just listed one highlight from each committee, and we'll go ahead and go to the next slide to save time, but just wanted to make sure that you're all aware of their great work. Also, there was a lot of committee collaborations that happened in 2021, both the Health Equity Committee, they worked with the MAC on the waiver, as well as the Health Equity Committee supported the healthcare workforce on the Health Equity Framework. And we also saw the HEC and Health Plan Quality Metrics Committee supporting the cost growth target on their measures. So try to make up some time. Go ahead and go to the next slide, but we'll go ahead and close it out there so we have enough time for some discussion, as well as the following presentation. So sorry that had to be so rushed, but that is in no way diminishing any of the great work that the board and the committees went through. When I was putting together these slides, I was really amazed by how much we did accomplish and tackle last year. So I'm hoping that you guys all feel somewhat proud of yourselves, because that was a lot of work and a lot of meetings and time. So thank you.
Thank you so much, Tara, and appreciate, I know you went fast through that. And just to take a moment and say, wow, that's a lot. That's a lot, and honor that. And especially as David pointed out in the beginning of our conversation, in a difficult year with COVID and a lot of other things going on. And so really want to just recognize that. So we do want to give a few moments for reflection on this before we move on to hearing from the committee membership work group and that discussion. But just, and again, thinking about the work and thinking in the past and the work moving forward. And so just want to hear if you have reflections, or specifically if you have thoughts about how the work of the board or the committee work sort of supported systems change, as we've been discussing, through anti-racism efforts to move towards that 2030 goal of eliminating health inequities. Just thoughts, where did you see this accomplished? Where, and to inform what you want to do moving forward. So what are folks' thoughts about where your work, the committee work, supports system change through anti-racism efforts and to move towards the 2030 goal? John, please.
Yeah, as I read this, I just thought that actually occurred over 42 hours of meetings. That's it. 42 hours. So it worries me that we got to make sure we're cognizant of the old saying, starve for knowledge, drowning in information.
Thank you. Are there reflections or thoughts from board members about?
Yeah, I thought it was really impressive to see all of this information put together in this presentation. So thank you so much, Tara, and anybody else who contributed to kind of organizing the presentation. You know, as we go along the work, and every month and every week, and we're doing our work, it's easy to forget sort of at a high level everything that is happening. So to me, it was really impressive to see everything that's occurred. One of the things I also noted, you know, in terms of the 4 priorities of the board, 3 of them have like actions to them, right? You know, ensuring our work is centered on health equity, like implementing, you know, the cost growth target program, and like making sure we implement the waiver renewal. But one of the things I notice is that the OHPB committees are just there. This is like, you know, OHPB committees, like they're there, something with them, right? There's no action around them. So I would love for us, as we move forward, you know, to really kind of create like empowering the committees or empowering and aligning the committees, a bit more of a focus on that as we move forward.
Thank you, Oscar. Other reflections on whether you saw this work supporting systems change?
Can you repeat that? You kind of cut out. I didn't hear you.
Oh, sure. I said where, thoughts about where the Health Policy Board and/or the committee work supports systems change? Pat, please.
Well, if I could, I think the most powerful thing that I have seen over the last really 2 years has been the Health Equity Committee's work that translated to the adoption by the policy board and then the agency around the definition of health equity, and in particular, the language about allocation and reallocation of power and resources. I think we really saw that play out as we made a big shift in how we responded to the pandemic, thinking about the equity, the $45 million equity investment that we made. And we're seeing that today with a lot of gear grinding, but I think still directionally correct around things like Measure 110, where who's at the table and who's actually making the decision is substantially different than it would have been had the committee and the board not pushed in that direction to really think about the fact that the people who are impacted by our decisions need to be the ones at the table making the decisions. I think that's had a huge impact on the agency.
And Pat, appreciate that. And just a reflection on this morning's conversations with the committees is that came up again and again. The health equity definition as a foundation and a sort of North Star and a driver and framework for the work.
Yeah, and as an actionable driver, right? Yes. You can actually see it and do things because of it that you wouldn't do in its absence, I think.
Other reflections from committee members on this? And some of it is just sitting with it and wow, that's a lot. But I want to see if there's before. Brenda, please.
Yeah, I also, want to recognize and commend the body of work. And what I'm sitting with, honestly, is this recognition of the complexity of the systems that we're in, that we're navigating, and a sense of just somewhat overwhelmed of how much further we have to go. So I know that this kind of transformational journey that we talked about both this morning and Clarice through your tee up requires such vigilance, and it requires such focus and dedication. And while we can mark progress and feel good about it in the moment, I feel this other urge around, yes, and not enough. So I'm just saying that out loud because it was on my mind and in my heart.
Thank you, Brenda. Please, Ebony.
Yeah, no, I appreciate with what others have said, and I want to kind of piggyback on what Brenda has said, also, and I think I probably say this at least once a quarter, that while we in this role and our various roles, are doing the work, are sitting around the table as we're trying to figure out how to do better, how to get it right, how to improve outcomes. Until we do, we have people suffering and we have people who are impacted. And so there's levels of privilege in even being able to sit around and have these conversations. And I think that, that this is a beast to move forward. And I think Clarice kind of spoke to it earlier of we can kind of determine based on what we're specifically talking about, the time frame of how long we've had maybe some of these system policies that we're trying to shift. And if we're looking at a time frame of 100 years, 50 years, 20 years, to then reflect on 12 months of work, you don't necessarily start to see kind of some of the impacts that you hope for. And so I think it's, yes, one thing that I celebrate is the intentional conversations that are being integrated in the work. without being asked and without being pressured. I think that that's awesome, and I think that's amazing. And at the same time, I think that what I hear a lot of, and I'm not going to call out any names or committees or things like that, is that that sometimes there's this concern that there's a setup for failure per se, so that then when we don't see the results of our labor, it's like, well, we left it to community and this is what they came up with. And so it's, how do we recognize kind of what the various pieces are that each person, each entity, each partner holds, whether it's OHA, whether it's the committee, whether it's the community, and who leads what. And the last thing I'll just say is that, because I think oftentimes, and I'm going to, be courageous and I'm going to be bold, oftentimes when it comes to, I'll say, racial equity work, I think traditionally what happens is it's people of color are asked to step up and speak, resolve, lead, and find the solutions. And I always say, as a Black woman, if my community had the ability to end racism, we would have done it a long time ago. And so that said, it's not just the responsibility, for example, people of color. And so I'm going to translate, it's not just the responsibility of the community. And so how do you empower the community, but then the community doesn't have the tools per se to bring something forward? And so how do we make sure that we're not just constantly adding to the swirl that gets us nowhere?
Ebony, thank you so much for that really helpful framing and thinking about this. In some ways, that's a really perfect segue, I think, to the next conversation we want to have. But I don't want to jump if any other board members want to weigh in. Just want to give you another moment. Okay, so that we want to move to this really important work that you all have been doing in partnership with the committee membership work group. And so want to turn it over to Leanne Johnson, Susan Utter, and Ignatius Bow. And we're just going to turn it over to you all and take it away. And sorry, we're running a little late. Apologies for missing some of that time, but you all can go right up to about 11:50. I hope 11:55. So go to it. Thank you.
Thank you, Diana. Good morning. I'm Leanne Johnson, Director of the Equity and Inclusion Division for the Oregon Health Authority. I am a Black woman, use she, her, hers. And by way of visual description, I have black graying hair. My background is a tan neutral. I'm moving in toward that senior citizenship that Dr. Santa spoke of at age 60. I am moving towards being considered an elder, and an elder in this work, which is quite overwhelming, and appreciate the opportunity to be here today to introduce the committee membership work group. And I think it's important to note that this is an opportunity to enact the values that we have espoused for many years around equity, anti-racism, representation, fairness, the many words that we use and hold them up as great words, but sometimes fail to truly make the changes that need to occur in order for us to eliminate health inequities, achieve health equity, and ultimately reach that 2030 goal of eliminating those inequities. So this committee work, I'll be turning it over to Ignatius and Susan in a moment. I also want to acknowledge, before I get into it, Don Jagger, our Chief of Staff and Director of External Relations. Don and I have served as co-executive sponsors for this work, just so you're aware of that. But this work has been an opportunity to truly assess for representation on our boards and commissions all the way across the board for that demographic representation, with a very specific focus on communities most harmed by health inequities, by social injustice, by racism, by oppression, by bigotry, by bias. And it's an opportunity to align with those principles, and the values that relate to health equity, and by acknowledging and once again enacting the fact that we're working to have additional feedback, redistribution of power and resources, and having the health equity expertise in the room as well as the lived experience, and that convergence is critical. Now, I say that because we've got to also, listening to this conversation that has occurred thus far, it is so important that the burden be on the system, and that the burden be on the individuals in the system that have created the system, and that we not further burden with invisibilized labor on the people that have been most harmed. And to points made earlier, we've got to acknowledge the toxic stress, the intergenerational trauma, the epigenetics of this impact, and the historical trauma of racism, oppression, injustice, and not create further burden and further responsibility where it is not due. And that being said, the system is needs to work to change, and we need to work to decolonize that system, as well as move toward dismantling the white supremacy that has created this system. So just adding diversity to a board or commission is never enough. That is tokenism. But we really have to think in terms of equity, and why are we broadening representation? And we have to also adjust in that for the power differential that exists, and the conversation of equity enters into that power conversation, because it is truly about that redistribution of power and resources. So on that note, that is the spirit in which we bring this work forward. I appreciate very much the opportunity to reflect on how this work can be value added and not burden added to the individuals and the communities that have been most harmed. And I believe that Ignatius Bow and Susan Otter and the committee that has worked on this have really taken that to note and taken that to heart. So on that note, so to speak, I'll turn it over to Ignatius and to Susan.
Thank you so much, Leanne. Good morning. My name is Susan Otter. I'm the Director of Health Information Technology, but also lead staff on the committee membership project. Next slide. And I use she, her pronouns. Today, we're going to present a very brief project update and progress, reflect on progress, but spend a little time with the baseline member survey results that the policy board and all its committee members completed, to give a base sense of where we are with diversity, health equity, lived experience, and other expertise and experience on our committees. Then we'll save some time for discussion and talk a little bit about our recommendations for the next steps on the survey. Next slide. I'd like to hand it over to Ignatius Bow, who's going to start us off with our project update and progress.
Great. Thanks, Susan. I'm Ignatius Bow. I'm a consultant to OHA. I use he, him pronouns, and I'm really excited and delighted to be able to present an update, and then to have Laurel Dennis share some of the actual data from our first baseline survey that we just conducted. Next slide. So just a brief overview for those board members who've been through this process with us, and to update the new board members. We began this work in December of 2020 with the chartering of this work group to really look at this question of committee diversity, but also, as Leanne really noted, it's not just a tokenism of trying to collect and report back the demographic data about committee members, but really in this longer term view of how to make these committees more inclusive, more responsive and responsible and accountable to the communities that they're supposed to be serving through their policy recommendations, and ultimately in service of the broader OHA goals of trying to achieve health equity. So we did a lot of analysis. We talked to nearly 30 community partners in this process, and we compiled a final report that was issued, next slide, in October of last year. And we really emphasized in this what we heard from community partners, which was that even having a conversation about committees and committee diversity wasn't the first step. The first step is really this authentic, ongoing community engagement, building that trust with communities that have been excluded and not represented and not heard, even though they've told their stories over and over again, as Clarice pointed out. And then we needed a more systematic process to collect this kind of data so that we could understand the actual diversity or lack of diversity of current committee members. That then we also then needed to move beyond just who is sitting around that table, but how that table then interacts with those lived experiences, cross-cultural experiences, health equity experience that diverse committee members will bring, and how those changes in how then the committee thinks and operates and functions can result in more equitable recommendations that will come forward from those committees. So lots of work yet to be done. We're focusing really on the second and third of these points of coordinating that recruitment and collecting of information and then reporting it back to all of you. Next slide. And so these are the overall recommendations that were in the report. I'm not going to go through these, but again, highlighting in the second row of recruitment and retention, this is really about that phase of recruitment and reporting the data out, that there are phases that have to happen before, and there's other parts of OHA that are working on deepening and broadening community engagement, and then there's more work that this committee, work group, and others will have to continue to do on inclusion and on equity. Next slide. So while recognizing that this is just part of that process, I do want to celebrate and acknowledge the hard work that the work group has done, and also the fact that even its creation as a cross-division, cross-office work group was something different for OHA, in a model, I think, moving forward of how, again, the assets, the strengths of the entire agency can come together to focus on something like this. We are looking at ways in which staff will continue to increase their level of communication and coordination with each other. There have been lots of conversations about recruitment, about what it means to identify more diverse members to bring on the committee. And then committee staff are beginning to ask those questions about inclusion and equity as well. We will need new resources from the agency to continue this work. I have been brought on as a consultant to help with that, and that kind of consultation, whether it's from me or somebody else, will also probably be needed until staff has greater capacity to actually take on and continue and sustain this work. And then one of the other things that Susan and I did was we went to every one of the committees and presented on this process of collecting this data and why it was important and what recommendations we had heard from the community. And so every committee, and those of you who are liaisons at those committees, were part of those presentations and heard that. We're engaged in those conversations about why this diversity, inclusion, and equity work is so important to the committees and to achieving that overall OHA goal of eliminating health inequities. We also conducted a specific educational webinar about why we were collecting the race, ethnicity, language, and disability data from committee members in the same way that we collected from Oregon Health Plan members. And there were a lot of questions about that came up in the survey. And we will need to continue that conversation so that we, again, socialize that as something that we want to do across the board. It's something we did during COVID, and we will continue to need to collect that data in all kinds of ways and in all kinds of surveys moving forward. Next slide. Back to Susan.
Great. So as Ignatius mentioned, we've been focused on the green arrow here in our implementation plan, which is the baseline survey, which we'll be presenting to you next. We've also had a gap analysis tool developed that we'll be using consistently across committee recruitments. We've been coordinating across committee staff as they do recruitments. We've brought on some additional resources to support committee membership recruitment and outreach. And then we've really are focusing on structural changes. We'll talk briefly about compensation and committee composition changes. We've got more work to go with engagement and recruitment and looking at inclusive practices. Next slide. I wanted to mention one area of structural change that's happened. We heard clearly from community about barriers to participating on committees due to receiving, whether they receive compensation. In 2021, the Oregon legislature made major strides in providing compensation to members of state boards and commissions who are qualified based on income. So that supersedes the existing statutes for committees related to compensation and makes compensation available at the same rate that the Legislative Assembly receives compensation for their time. So this is an exciting advancement in this work. Next slide. And we'll be working to roll this out for all of the board's committees and all of our committees that are where this is applicable. There is some restrictions in statute for non-qualified members. And so we'll be taking a closer look at that, where we have individuals that make more than the qualified amount, but are not receiving compensation from their employer, for example, or losing revenue from their independent business. So we may need legislative changes to clean up some of our statutes to allow flexibility for those members. And then the bill that passed isn't without some challenges. This does add taxable income to individuals when they receive compensation for their time, which could include, has its own complications. So we'll want to be really clear and transparent as we roll this out, as well as looking at, are there other changes that might be needed in the future to tweak the legislation that passed. So that was super quick about compensation. Next, I wanted to hand it over back to Ignatius and Laurel to walk through some of the survey results. And we want to save some real time to hear your feedback and observations about the baseline survey and other thoughts you have about this work as well.
So thanks, Susan. Next slide. So I'm just going to provide some very high overview and highlights, and then turn over to Laurel, who's really done so much work in cleaning up the data and making sure that we are eliminating duplicates and all kinds of other technical things that I won't get into. So next slide. So the great news is we got terrific responses from all the committees. Overall, 85% responded of current committee members. And these range from 71% to 100%. 3 committees, the Health Equity Committee, the HITAC, and the Healthcare Workforce Committee, had all its committee members respond to the survey. This took a lot of staff effort. The lead staff, as well as Tara, worked really, really hard over the last couple of months to get those responses from all the members. And this is, again, really important because it's so important for us to have this information so that we can see where we can improve. Many who participated in the pilot of the survey last fall, who were applicants, not yet members, actually noted we did a follow-up survey to ask about the user friendliness of the survey. And many actually noted that they said this would be, had comments like, this made me feel like I was seen and I would be heard if I were selected to be on the committee. This made me, one respondent actually said, this really operationalizes the OHA health equity definition in a very concrete and specific way. This is the first time we've collected this level of race, ethnicity, language, and disability data in a disaggregated fashion. as well as the sexual orientation and gender identity data. And so again, it's going to be a really fascinating look for you to see how people responded. And we did do some comparisons to not just the population, but the population that is served by government programs. So mainly low-income folks in Oregon. Next slide. So here are some of the highlights. Again, the good news is there were no categories in which there was zero, that there was no representation across the committees, and that's really, really good news. So we can't say that we can't find somebody with a disability, or we can't find an Asian American to serve on this particular committee, that we are doing a good job of reaching out to the diversity of Oregon. There's lots of opportunities for growth and improvement, particularly in the Hispanic Latino category, where there is significant underrepresentation. The other good news is when we asked about health equity experience, 8 out of 10 of those who responded said that they had some health equity experience. Whether they're bringing that experience to the table in the committee conversations, we don't know, but at least they're reporting that they have some familiarity and experience with it. 60%, 2/3, said they had brought some lived or cross-cultural experience to their committee membership, and that's also really good news. And again, probing, are committee members bringing their full selves? Are they showing up with all those identities, with all those experiences, and contributing to the conversation about those experiences? And then also pretty significantly, about 1/3 reported experience as actual OHP members. 13 are current members, and 19% have been members in the past. So again, bringing that specific lived experience to the committees themselves is also really important. Next slide. So before I turn to Laurel, there were some questions continuing, as we would expect, of what we mean by lived experience and cross-cultural experience. And this board will have a real great role in continuing that conversation and emphasizing how important that is. That, as expected, people continue to have some concerns in the user survey afterwards about confidentiality and how we would use these results, and we've made sure that they have been kept confidential, and that only Laurel has been the one that has been looking at them and then aggregating and reporting them. And so again, how we move forward and whether or not we also need some potential legislative or charter changes to make sure that this information, as we ask for more of it moving forward, will also remain confidential and protected. And then finally, just to highlight, we'll have discussion about this at the end, that this is really just one step in the continuum, and that this really then begs the question and raises the question of, are the ways in which the committees operate and function really lifting up these experiences? Are they being inclusive? And are they really, again, taking advantage and leveraging all this diversity that has been reported in this survey? So now I'm going to turn it over with many thanks to Laurel for all her work over the past couple of months, and ask her to report some of the more detailed data. Laurel?
Thank you. Hi, I'm Laurel Dennis. I was a research analyst. I'm transitioning into a new role, but for the purposes of this presentation, I have my research analyst hat on. Okay, next slide, please. Ignatius did a great job of pointing out some of the response rates. So I won't spend too much time on this. I would just note there were actually 4 committees that reached 100%. And across the board, we saw strong responses from all committees. I want to note that we included current members. There has been member turnover, and so we were able to include new members when they came on and excluded some members that had left committees. We also excluded ex officios in the analysis, and so they're not represented here in the response rates or in the rest of the results. Next slide, please. We are looking at racial or ethnic identity in 2 different ways. So on this first slide here, we are looking at primary racial or ethnic identity, and the way that we went about identifying the primary racial or ethnic identity is members who responded by selecting one category that was their identified primary race or ethnicity. And for members who selected more than one, there was a follow-up question asking if they identified a single race or ethnicity as their primary. And if they elected not to choose one or chose something else, they were either identified as biracial, or they identified as biracial or multiracial, or selected that they didn't have a primary identity. And as Ignatius pointed out, we're using two different points of comparison. We have the population statewide, ages 0 to 64, which is in the blue pattern bars, and we have individuals who are using government-funded health plans or receiving assistance in the yellow patterned bars. As you can see, there are certain groups where membership is overrepresented, such as the Asian category, where members were 10% of members identified as Asian, and there are several racial or ethnic groups that there is underrepresentation. Next slide, please. The second way that we looked at racial or ethnic identity was by looking across all selections that members made on the survey. And so members may appear more than once if they selected more than one category. So the percentages here will not add up to 100%, but it gives a better picture in some way of seeing the representation within subgroups. And I think it paints in some ways a better picture of and maybe a more accurate picture of how people identify. I noted that the percentages won't add up to 100%, but you can, by looking at this, you can see, for example, 6% of all respondents identified as American Indian, or 3% of respondents selected Indigenous, Mexican, Central, or South American. So I would, unfortunately, we can't spend a ton of time on these slides, but definitely take your time and look through them when you have time to do so. Next slide, please. For gender identity, we did not use a comparison population here. It didn't seem appropriate, but you can see that 59% of members responded that they are women and 39% men. We combined non-binary questioning and other categories that were made available, such as agender. We also had the opportunity for members to write in if they didn't feel that any of the categories captured their gender identity, and those are all combined under that third bar. Next slide, please. For gender modality, we found that 3% of committee members responded that they are transgender. Overwhelmingly, 93% identified as cisgender. And for a comparison population here, we have our source is the UCLA School of Law. This resource is a little bit outdated. It's from 2017, but important to note that at that time, 0.65% of adults aged 18 or older in Oregon identified as transgender. Next slide, please. For sexual orientation or identity, again, we grouped here several categories. So LGBTQ+ is inclusive of lesbian, gay, bisexual, queer, and then other sexual orientations or identities, both ones that were provided and if members opted to write in their own sexual orientation or identity here. And then, so that's 14% of members identify as LGBTQ+, and 76% identify as straight. Next slide, please. I think in the interest of time, I actually am going to skip forward a few slides to slide 24. right here. So health equity experience, this is where we saw an overwhelming response of members saying that they have health equity experience. Overall, 79% of members said that they do have health equity experience. And then I went through and kind of pulled out categories or themes to responses. And so of those who said that they have health equity experience, 40% mentioned something related to policy, data analytics, research, or organizational operations. 32% mentioned experience directly serving a diverse population, whether in a clinic setting or some kind of organization. 29% mentioned some sort of training or education, and 10% mentioned a membership on some type of board or committee or council related to health equity. And people may fall in multiple, the responses were pretty robust, and so people may have fallen into more than one of these categories. Next slide, please. As far as lived and cross-cultural experience, you can see here 67% of members responded that they have some cross-cultural experience or lived experience, and 54%. So as you can see, there's some who mentioned only cross-cultural experience, some who mentioned only lived experience, and then some combination responded that they have both. Susan, should I continue or do we need to leave some more time?
No, go ahead.
Okay. I think I'll move forward to the next slide then. I wanted to point out here the members who responded about their experience with communities, and just note that this isn't representative of people who are who belong to these communities. It also includes people who work with these communities. So as you can see, communities of color and or immigrant or refugee communities, most members had the most experience with those communities. And then obviously in descending order, the remaining communities, persons with disabilities, LGBTQ+ communities, and tribal and or indigenous communities. We had quite a few members write in with their experience serving other communities, such as people with lower incomes or people experiencing poverty or people involved in the foster care system. Next slide, please. Ignatius mentioned already that 32% of members have experience as an OHP member. I did just want to point out that there were a few other interesting percentages or findings. Public health, behavioral health, social services, and oral health percentages are also up there. Oral health actually is towards the bottom though, but we did find that of interest given membership. And next slide. On this slide, I wanted to just point out that 19% of members responded that they represent as an advocate or consumer community representative or advocacy organization, and 19% also responded that they represent as a consumer or community member. And towards the bottom, 2% of members responded that they are representative of tribal nations or other tribal representative. For this particular question, we asked members to select up to 3 sectors that they represent as a member of their committee. And so members may be reflected in more than one category here. And the last slide, I won't spend too much time on this, or I won't spend time on it, but all of these findings are included in the committee level handout. And I think that is it.
Great, thanks so much, Laurel. If we could go to the next slide. And the next one. So we do want to stop presenting and really turn to the board members for your impressions of the data. Were there any surprises? Were there any concerns? And then I think most important moving forward is how do you think the work of the board and the committees would change, back to Clarice's framework of we have to reconstruct and change the systems, how would changed committees operate? What would be different if this diversity were increased. So board members? John? You're on mute.
Yeah, I'm recalling that the board and the equity committee endorsed the inclusion of age in the definition. My recollection is I believe I saw some data suggesting that seniors were underrepresented in committees, and urged that we look at both extremes in terms of age. It's important that children and the folks who advocate for children, parents, I think we make sure that those folks are there, and we make sure that the population that is sickest and is most using the healthcare system, including, OHA, I think has 150 to 200,000 dual eligible folks. So they have a large population of seniors that they're responsible for. And I think seniors would be a very potentially good source of committee members. Many of us have more time, we're more flexible, and we certainly have experience. So I just wanted to bring that to your attention.
Thanks, John. And there is data broken out by age in the full chart pack. So other board members? Any surprises? Any concerns about the data?
So I just have a quick comment, and it was regarding into your definition of health equity. And some of the committee and commission members really didn't have that definition that was concrete for them. And there was a lot of questions posing around, what is this board? How are they educating those individuals, whether they are OHA members or Oregon Health Policy or Oregon Health Plan members, or other groups that maybe really didn't understand that and where this wants to go. Because when you say at some point, or Leanne brought this up, that they needed to create an advanced system changes and policies that result in reallocation of resources and power. I think it's a strong definition for myself. And how does this board get to that level of commitment moving forward in advancing opportunities for health equity? So that's just something that I feel that is a need when I read what the definition of health equity has become, and then just because of some of the things that was stated during the earlier session, and especially it's in regards to lived experience and context expertise. And how do you break it down to a cellular level? So that's big for me, and I'd like to see that happen. But how it's done, that's why we have individuals like yourself as experts to break down into a cellular level. So thank you.
So thank you, Sandy. And clearly the definition was, upfront in the survey. It was part of the presentations that Susan and I did to each of the committees, and so, to the extent that any committee member had not seen it or heard it or had thought about it, it was in front of them. And I think the questions now are exactly the ones you're asking, which is then how does that get operationalized? What's the role of that committee and that committee member in making that health equity come to life? And I think folks are asking that question and may not have their answers, but we want them to struggle with that and work through that with the committees. Ebony?
Yeah, and I appreciate what Sandra spoke to. I think like the one thing that I, just found myself wondering and thinking about was, when it was noted around kind of experience with, the various populations, kind of what does that mean, and do what? How do we measure effectiveness per se, and in terms of okay, so just because I've worked with another African American person, does that mean that I was effective? And again, with some folks have already kind of brought forward of not necessarily always feeling like folks are fully equipped to do some of the work specific to the equity piece, and or even not knowing how to improve strategies to get to better outcomes for certain populations, then, like, how do you gauge, yes, I have experience with this population? And so again, just a random thought, not necessarily looking for a response per se, but like, that was just one thing that a recurring thought I had.
Absolutely. And again, each committee has to work through. So even, this is probably the first time that it was disclosed that people may have been an OHP member or had that kind of experience. And so again, how does that person bring that experience forward? It's one person's experience, but it is useful in that committee process. And so again, committees will have to work through the chairs and the staff to figure out how to lift those voices and perspectives up in the conversations at the committee. So I see Bill, Oscar, and Brenda, and then I think we're going to have to close. So let's get Bill, Oscar, and Brenda in.
I have a question about some item that was in the final recommendations, and then maybe also about the survey. One of the recommendations had to do with implementing more inclusive meeting practices, which all sounds good, and and then implement the work on equity. One of the things that I've been concerned about, and Ebony somewhat touched on this, and others have as well, is not just having people in the room where it happens, but also having the right people in the room where it happens, but also giving them the information, the tools, the knowledge, the expertise, so they can contribute fully. So everyone in the room can contribute fully. To what extent do you think that that's we have concrete plans to move forward on that? And to what extent did that come up in the survey as an area of concern for committee members?
So very quickly, it did not come up in the survey, but it is part of the report, and there are recommendations, and then the work group is starting to look at ways that those practices, compensation is clearly one of them, to make it more equitable for folks to participate in those committee meetings and not have to feel like they're sacrificing by their time. So again, I think there are going to be many more ways in which inclusive practices and ultimately equitable practices can be implemented. So Oscar and then Brenda.
Yeah, just a couple of really quick thoughts. I'm so appreciative of how far we've come in the presentation and all the work that's been done over, the year plus, gathering this data, analyzing this data, and presenting this data. I think it's such a critical, first step into sort of this systems change work that we're all trying to move. So, I just want to make sure that we continue to resource this work. This work is really important to continue to figure out how we invest in it, move it forward, to do more of this alignment that we heard in the morning, right, from committees, to help us with aligning recruitment practices, and also to really kind of further articulate best practices around retention. Once we have, these folks in these committees, how do we make sure that we honor their commitment, honor their time, that they feel valued, that they feel heard, so that we're not sort of having this sort of revolving door where people come in, they feel like, oh, this is not a great use of my time, and then they move out. So thank you so much for all of your work on this.
Great. Brenda?
Thank you, Oscar. And Bill spoke to the issues around inclusion, recruitment, and retention, which I know will be embedded in our ongoing workflows. My question, perhaps for the work group, is to speak to the systems themselves that have been siloed committee by committee, everyone doing their own recruitment process, their own onboarding and engagement process, and what we're learning about how critical it is to do cross-committee work. And I wonder if you could just take a moment to speak to the systems that are going to support more of that cross-committee or that larger picture view. Yeah.
So that's a perfect segue back to Susan for the wrap up.
Sure. So we have a number of things underway. One is to start to just even collate the data around committee members and applicants into a common system that staff can be using. We've brought on new staff that'll be supporting committee outreach for consumer members in particular, that will be working across committees to engage around upcoming recruitments that'll be needed. And then we have further work to do in terms of a common staff guidance for onboarding, for example. I think we have a lot of opportunities with common tools. We do have now a final gap analysis tool for assessing what gaps there are when recruitment comes up that will be used by all the committees. But I think there's opportunities for us to use common charter templates and other things. We've also talked about exit interviews to really assess some of that, where we have turnover, are there things that we could be doing differently? So that doesn't mention the other work that we've highlighted that we need to do to, I think, really look at staff and, chair and vice chair skill sets around inclusive practices. So probably some training will be needed. And so that'll be one of our next steps to look into that component. And then the last thing I'll mention, instead of returning to the slides, I'll just mention this. We'd love to continue the work with this survey and update it to be used for recruitments that come up. We think it's a good tool to have a common tool. Each committee will have their committee specific questions they'll need to ask about things specific to the committee, but we'd like this to be the common tool behind all of our recruitments coming up, or for especially as we bring on new members or proposed slates. And then the other component is we'll be looking at legislative and charter changes that might be needed to clean up some of the restrictive components about how committee membership is specified in statute or in charters. So those are some of our other kind of structural components that the committee will be taking a look at.
And just to add, Susan, and the recommendation is that we would give existing committee members an opportunity once a year to update their information. So that, again, they may have accumulated some cross-cultural experience if for whatever reason they wanted to change their demographic responses. And then we will collate those and report back to you as a board once a year, again, snapshot in time to try to make sure that we have the current committee members as the committees evolve and change and there is some turnover. And so that you'll see from year to year at least whether or not there is progress being made on diversity, especially in some of those areas where there might currently be some underrepresentation.
Okay, anything else, Susan, Leanne, or Ignatius, before we move to wrap it up? Thank you so much for that. And really does connect to the apologies. My phone, my computer started dinging. But that really does connect to where we started this morning in terms of those conversations with the committees. And Clarice is going to do a wrap up in a moment, but I wanted to preview a little bit tomorrow. So we are going to be getting an update from Pat and Leanne, a little bit more on some of OHA's work. focused on all of the work, but also on getting to that 2030 goal. And then you all will really be in conversation about your 2021-23 priorities and cost growth. The committee work will continue that discussion, coverage, and obviously health equity runs throughout all of that. So there'll be some brief presentations tomorrow, and most of the time will really be spent in you all in conversation with each other about sort of focusing that your upcoming work based on sort of where you are, where the health authority is, and how you want to continue moving forward on your areas of work. So with that, I'm going to turn it over to Clarice.
I think we want to say thank you most of all for all of the work today. And thank you for what's coming. You know, what we heard was system change is dependent on collaboration, on doing the work differently together. It's dependent on people not only being, you know, like being empowered to do self-directed activity, but also for there to be space for folks to do and bring what they know as equal expertise. You know, thinking about what needs to happen to ensure the capacity, right, the knowing, knowledge, all of that of the community has to happen simultaneously with those in power or with power and privilege to do their work, to be able to share the power and the resources that they hold. So it's a both and it sounds like you heard that from committee, you heard that from each other, you know, that's where we are. We're grateful. We're grateful for the opportunity to spend the time with you and to poke at you and to think with you. We'll be back here tomorrow morning, 8 o'clock, ready to rock and roll. Have a great day. Take good care, drink water.
Thanks, everyone.
Tomorrow.